Nurses and providers provide a critical role in assessing and managing distressing signs and symptoms during end-of-life care. In this module, I'm going to discuss some of the more common signs and symptoms that you'll encounter during end-of-life care. I'm also going to talk about the epidemiology, the pathophysiology of these signs and symptoms, and then also give you some objective tools that you can use to help assess these signs and symptoms during this stage in your patient's life. All right, so some of the outcomes for this module are going to be identifying common distressing signs and symptoms during end-of-life care. I also want to give you objective measurements and tools that you can use to evaluate pain, agitation, and dyspnea. And then also I want you to be able to use these tools to assess the above signs and symptoms like pain, agitation, dyspnea. So there are many conditions that cause patients to be admitted to critical care units. And also with the variety of conditions that cause patients to be admitted, there are many reasons for them to deteriorate. Within all of those disease processes, there's going to be different signs and symptoms. And so every patient really has a unique experience during end of life. But some of the common signs and symptoms that we see during end-of-life care that are shared with a lot of patients include pain, terminal secretions, delirium, dyspnea, and nausea and vomiting. And so through identification of these experiences, the nurse can advocate for their patients to have their dignity maintained and then provide support for both their family and the patient. So pain is a common feared symptom at the end of life. There's a lot of literature surrounding pain and the epidemiology of pain at the end of life. There's actually some literature that shows that it occurs up to 96% of patients during this stage of life. It's defined as a physiological response to tissue injury or intense stimuli. It can be acute or chronic, or really in these situations, oftentimes it's both. And so when nurses are caring for patients that are in the end of life, expect to be treating pain. Pain assessment during end-of-life care can be complicated. There's some research out there showing that one of the barriers to effectively managing pain is the assessment part of pain in end-of-life care. So it's really important to understand how acute pain presents and how to use some of the tools during end-of-life care. So acute pain is transient. It can have a sudden onset. Some of the signs and symptoms that you can see with acute pain include anxiety, hypertension, tachycardia, and diaphoresis. Some common behaviors that you might see with your patients include moaning, rubbing, or even splinting the area. So there are many tools for pain assessments. There's not a lot of research on using those tools during end-of-life care. One of the most common tools that we use is the nonverbal pain assessment. And so healthcare teams, and this is the pain assessment tool that's up on the screen with me, we can use this to kind of grade our patient's pain based off of how they're presenting, what their vital signs look like, and what their behavior is like. I always say use this with caution during end-of-life care because, as you know, the physiology in end-of-life care is very different and their vital signs may present different as opposed to a normal patient that is, using the same tool. Another interesting one is there was this trial called the support trial. And what they did is they had patients that were able to communicate and a partner, it was like a loved one or just someone that knew the patient well, and they'd ask this partner, they'd say, how much pain do you think your partner is in? And then they would answer, and then the patient would also answer. And we'd get two separate answers, they weren't talking to each other. And what we found through the support trial was that around 73.5% of proxies, like the family members, would actually be able to identify when their loved one is in pain. So I think with this information, it's really important to reach out to loved ones, family members, people that are at the bedside and ask them, like, you know this person much better than I do. Do you think they're in pain? Do you think their symptoms are being controlled right now? So like I said before, there's really not that much research on pain assessment tools at the end of life. So use your clinical judgment on what tool to use, and then also always remember we have family members and loved ones that know the patient much better than you do. All right, the next sign and symptom I'm going to talk about is delirium. So delirium is a cognitive disturbance that's characterized by global cerebral dysfunction. This often includes disturbances in attention, level of consciousness, and then basic cognitive function. Delirium at the end of life is often confused with dementia. Dementia is more of a progressive decline and is a chronic disorder, where delirium is an acute disorder. This is often accompanied with agitation, hallucinations, and paranoia. Delirium is very common in end-of-life care. It's encountered in both critical care patients and end-of-life care patients, and so it's reported that about 70 to 87% of ICU patients have delirium, and around 83% of end-of-life care patients have delirium. So based off of these two groups have high percentages of delirium, I would expect to see a lot of this when you're caring for your end-of-life care patients. So I want to give you a couple tools to assess delirium and then also agitation. So kind of one of the gold standards to assess delirium is the ICU confusion assessment method. It's also called the CAM or the CAM ICU. This tool is very useful if the patient is able to participate, but as you can imagine, it can be difficult to perform this on end-of-life care patients. Some of them may be able to participate, some of them may not be able to participate just due to their condition at the time that you're performing this test. So if you're able to perform this, that's great. If not, you should be comfortable recognizing some of the concurrent signs and symptoms with the delirium. And so that really includes any like change in like their consciousness, any change in level of arousal, altered sleep-wake cycle is very common, mumbling speech, disturbance in memory or hallucinations, and even agitation is common with delirium. So as stated before, delirium can often present with agitation. Agitation can be assessed through a Riker scale. There's many other tools out there to assess agitation, but the one that we use at the University of Utah is the Riker scale. And it's a scale that ranges from 1 to 7. 1 is typically unarousable, and then 7 is dangerous agitation. So this scale really allows the clinician to convert subjective observations and then turn it into an objective measurement. During end-of-life care, we shoot for a Riker of 4. Oftentimes, it's very variable on where your patient stands, but 4 is something that will provide quality for both the patient and the family during end of life. All right, the next sign and symptom is very common in end-of-life care, and it's dyspnea. So it's really a subjective experience, or one is very aware of their breathing. And so this is really like a mismatch between your respiratory drive and then how much oxygen you're getting in and what your CNS senses with how much oxygen you're bringing in. It's estimated that around 94% of patients with terminal disease or in like the end of life stage will have some type of dyspnea. So dyspnea has many concurrent symptoms that may cue the provider or the clinician into the process. So one of the first ones that you may see is tachypnea. And so this is not only like a concurrent sign of dyspnea, but it can also be a cause of the disorder. And this is due to the mismatch between ventilation and oxygen. So remember during end of life that the vital signs may not be like an appropriate measure of any of these signs or symptoms, including dyspnea. And so tachypnea may or may not be present in your end of life care patient, depending on their process. Another sign that you may see is color change. This can show like pallor or cyanosis, and this is another sign of a mismatch between ventilation and oxygenation. Something else that you may see is grunting. And so this is an audible sound when the patient breathes in, and really it's just showing that the patient is trying to keep their lungs open. It's a method that people use to keep their lungs open when they aren't getting enough oxygen. And then the next one that you would see is nose flaring. It doesn't happen a lot with adult patients. It's typically more seen in like the neonatal population. All right, a few more signs of dyspnea. So another one is retractions. And so this is a sign of labored breathing. And so it can appear as like the chest is almost sinking in. And they go at various levels. Sometimes you see them underneath the clavicle. Other times you'll see them above the clavicle or even like within the intercostal muscles. Another sign that you may see is sweating or diaphoresis. This is kind of in response to the increased effort for breathing. And then it's not uncommon to see changes in body position to assist with ventilation. And so one of the more common ones is tripoding, and that's almost, you'll see the patient bent over and putting their hands on their thighs. One thing to think about with body position is that it's not uncommon, again, for patients to become in more distress when you change positions. So that if you lay them flat or if you roll them to one side or another, and this really just depends on the physiology of their disease process. For example, pulmonary edema, if you lay them flat, they're going to become profoundly more short of breath. And so it's important to recognize, like, if your patient is in some type of respiratory distress and it's end of life care and you've treated them with, opioids or other tools to help relieve this symptom, you can also sit them up in bed, and that may relieve some of that respiratory distress just based off of what their physiology is like. So as I stated before, dyspnea is a very subjective experience, and if your patient is cognitively intact, you can just ask them, are you feeling short of breath? Do you feel like you aren't getting enough oxygen? But oftentimes in end-of-life care, these patients are not able to communicate that type of need. And so there's this tool out there called the Respiratory Distress Observation Scale. It was created by a nurse researcher named Margaret Campbell, and it's used to assess the presence of dyspnea. And so there are 8 objective variables on the scale, as you guys can see here. Each variable is rated from 0 to 2. And so it's a validated tool that's very appropriate to use for end-of-life care patients specifically. And so a score of 0 to 2 on the scale means no distress. 3 would equal mild distress. And then 4 to 6 signifies moderate distress. And then an RDOS, or Respiratory Distress Observed Scale, anything greater than 7 would equal severe distress or even a palliative care emergency. All right, now that we've discussed a little bit about how to recognize distressing signs and symptoms during the end of life, the next module I'm really going to focus on managing these signs and symptoms using both like drugs, pharmaceuticals, and also some nursing cares that you can do.